So it is my pleasure today to introduce our presenter. Her name is Heather Brown. She began her nursing career in 1991 as a public health nurse on Fogo Island. She practiced as a registered nurse in community health, long-term care, and rural emergency, where she worked and studied to develop her leadership skills. With over 15 years of healthcare leadership across the continuum of care, she has expertise in executive management, evidence-informed decision-making, and rural health planning. Ms. Brown holds a Bachelor of Nursing and a Master's of Education, both post-secondary studies from Memorial Universities, and she received an Executive Training in Research Application Fellowship from the Canadian Health Services Research Foundation, which is now Healthcare Excellence Canada. In June 2018, Heather Brown became the President and Chief Executive Officer of Labrador Grenfell Health, serving a population of over 35,000 people living mainly in rural and remote communities along Newfoundland's northern peninsula and across Labrador. She is passionate and person and family centered and is thankful for the guidance and partnerships with the Indigenous leaders and communities to improve the delivery of culturally safe care. So it is with my pleasure now. I see Heather is on. I'll ask you to unmute yourself and begin your presentation.
I think you can hear me.
Yes.
Perfect. Great. I just want to try to get all those pieces out of the way first.
Yes,
If I
we're all
have a
good.
little technological faux pas, you'll have to forgive me. Thank you very much. I just want to thank the college for the invitation to do this presentation today. I really want to acknowledge that I'm only one voice, and I represent both registered nurses and other healthcare providers in our region in the work that we're doing, but more particularly our Indigenous partners, Nunatsiavut Government, Musho Innu First Nation, Sheshe Innu First Nation, and Nunavut Community Council. We are partnering together in this work. I'd like to start with a land acknowledgement. We respectfully acknowledge the territory in which we gather as the ancestral homelands of the Beothuk, and the island of Newfoundland as the ancestral homelands of the Mi'kmaq and Beothuk. We recognize the Inuit of Nunatsiavut and Nunatukovut and the Innu of Nitassinan and their ancestors as the original people of Labrador. We strive for respectful relationships with all of the people of this province as we search for collective healing and true reconciliation and honor this beautiful land together. Some people may wonder, why are we even doing this sort of a presentation and talking about cultural safety and the importance? One of the main reasons why we're here today is that we do know that racism is a determinant of health. The Social Determinants of Health, the Canadian Facts by Dr. Dennis Redfield and other contributors describe racism as one of the determinants of health, and that our determinants of health fall into really two categories, one being of social exclusion based on factors of identity, and social safety net and based on ways of responding and some of the different ways that people may be disadvantaged based on social safety nets. In the document, the Health Court NL document just released, social exclusion is defined as specific groups being denied the opportunity to participate in social life with limited access to social, cultural, and economic resources. Indigenous peoples, people of color, recent immigrants, women, and people with disabilities are especially likely to experience social exclusion. Socially excluded persons are more likely to be unemployed and earn lower wages, and they have less access to health and social services and means of furthering their education. Excluded groups have little influence as well on decisions that are made by governments and other institutions. And we may think, well, how might these factors influence the provision of health care in our country? As an example, in reference to Indigenous peoples in our country, what we do know is that lack of trust in the ability of our healthcare system to provide for Indigenous peoples creates barriers to accessing services, particularly for chronic disease prevention management, for screening programs, prenatal care as an example, and also the inability to access services in these ways can lead to increased urgent and emergent care and an overall reduction in health outcomes for Indigenous peoples. So racism I find it really interesting. It's a belief or a behavior based on the notion that race is the basis of human characteristics and practices, and that racial differences produce inherent superiorities or inferiorities of particular races. And that's a Webster's dictionary. But when I think about that, the fact that we've in our society that color of skin or where your cultural beliefs, your values denote inferiorities or superiorities in particular races, I often reflect on how does my whiteness influence my thoughts? How does it influence my personal values? And even more particularly, how does it influence my standard of practice as a registered nurse? And I would invite you, to think about that as where we are and whether or not the fact that for many of us online, we have a fairly homogeneous society in our province as registered nurses. How does that influence on how we see ourselves and how it influences how we think? We know that there are 3 forms of racism, and all of which do influence health outcomes. So institutionalized racism is concerned with the structures of law and society and may be reflected in practice, in laws, in government actions or inactions. Particularly from an Indigenous ancestry perspective, the health of Indigenous peoples in Canada is strongly influenced by their history of colonization. And this action has taken the form of such legislation as the Indian Act, disregard for land claims, and of course, what we now know recently, of course, is particularly the relocation of Inuit communities and the establishment of residential schools across the country. And I do want to take the moment to acknowledge that in our province, there were 5 residential schools. Lockwood School from April 1st, 1949 to June 30th, 1964 in Cartwright, Labrador. The Makovic Boarding School from April 1st, 1949 to June 30th, 1960 in Makovic, Labrador. The Nain Boarding School in April 1st, 1949 to June 30th, 1973 in Nain. The St. Anthony Orphanage and Boarding School, April 1st, 1949 to June 30th, 1979 in St. Anthony. And the Yale School from April 1st, 1949 to June 30th, 1980 in Northwest River, Labrador. And I would challenge you, it's important to educate ourselves as Canadians and as registered nurses about the impact of colonization in our country and the impact on Indigenous peoples. The second type is personally mediated, and this is defined as prejudice and discrimination and can manifest itself as a lack of respect for individuals, suspicion, devaluation, scapegoating, dehumanization. And in the healthcare system, personally mediated racism impacts the quality of care. So anytime there's any chance that I think of us against them, stereotypes of all Indigenous people have issues with alcohol or drug use, those sorts of pieces, and the dehumanization and not seeing the individual are examples of personally mediated racism. And we don't have to look very far in the recent past for some particular impacts, particularly with what we had learned from the Joyce Eschwan case in Quebec in the last couple of years, and how even in terms of our own personal feelings or in a group, how that might impact on how we provide care in the health system. And the third, sadly, is the internalized racism is when those who are stigmatized accept these messages about their own abilities and their intrinsic lack of worth, and it can lead to resignation, helplessness, and a lack of hope in peoples that feel that they are stigmatized. So the impacts of racism, I was really happy to read the CNA statement of September 30th, 2020, which some of the pieces, they say that racism is an important determinant of health, contributing to unacceptable health and social inequities. And while there's no fix to this massive systemic problem, the CNA believes that ongoing racism and discrimination are the root causes of health disparities that need to be tackled aggressively on all levels. And at that time, the CNA committed to actively confronting racism and dismantling oppressive systems that have created inequities both within nursing and the broader society. I believe that was a really important statement to be made. And when we think about the health impacts, we know, as I mentioned a little earlier, that negative experiences such as longer wait times, fewer referrals, and disrespectful treatment have been findings in Indigenous peoples in our country, and that source is from the National Collaborating Center for Indigenous Health. What we do know is that we know that reduced trust in the ability to meet the needs of Indigenous people creates emotional and social harm. A loss of trust in the healthcare system reduces the utilization and people's likeliness to seek supports, seek the services that they need, and that in itself leads to diminished health outcomes. And we know that from what we know to be many health outcomes of Indigenous peoples in our country, and certainly recognized. Joyce Eschwan died of pulmonary edema, and excessive fluid in her lungs, according to the testimony of Dr. Elaine Webencoeur, an emergency physician at the Montreal Health Institute. And the coroner inquiry looked into her death and how the health system treats Indigenous peoples. And we may think, well, how could this happen? And even as a registered nurse or another healthcare professional, you may think, well, how could that happen? But I think it's important for us to look at individual and systemic contributors. What is the impact of personal mediated racism on the direct delivery of services to people? And what could institutions do differently? And I don't believe that we need to be looking towards a culture of blame. I think we need to look towards a culture of reconciliation and look at how we can move forward together. So what is a registered nurse's response? Well, I've looked at a few of our roadmaps for sure. And first of all, in the CNA Code of Ethics, we are to promote justice and not to discriminate based on race, culture, spiritual beliefs, and other factors. Respecting the history and interests of Indigenous peoples, the CNA speaks to that and references the Truth and Reconciliation calls to action. And certainly warns about labeling and judging and stigmatizing individuals or groups of people. In our own standards with our college, I reflected on a few of those, and 2.3 under knowledge-based practice recognizes that we need to practice within our individual level of competence and seek additional support when needed. Most of the time, I think that we think about that in terms of our clinical practice, but I do believe our competencies in the delivery of culturally safe care is also a clinical competency that we need to be thinking about. And that knowledge comes from learning, and I'll speak a little bit about that later as a registered nurse in your journey. A second one, of course, 3.9 under client-centered speaks about reflecting diversity and promoting cultural humility and a culturally safe environment for clients and members of the healthcare team. And that struck me because, sometimes I know there's many people on the line who may not see yourself as working currently in your practice with other cultures. But I think that most of us certainly collaborate with colleagues who are of other cultures. We're very happy to see immigration, to see the number of colleagues that have come from other cultures that we work together. So how does that influence my day-to-day practice and respect for my colleagues? And when I do have the opportunity to provide care for individuals from other cultures, again, certainly the opportunities that we're seeing with new Canadians and maybe Indigenous cultures in our own province and other cultures, I believe there are a lot of opportunities to think about this and to look at how it is that we value diversity and promote cultural humility, and how do we create that safe environment. And under leadership in 4.4 speaks to individually and collectively advocating for healthy public policy and programs that are informed by the determinants of health. So I think that all of those pieces call us as registered nurses to think about our care and how we provide care and the standards that we strive towards. The third piece is reflective practice. And I think as a registered nurse, we have to be reflecting on how we provide care. There's a really nice tool, actually, and I can certainly provide the links later. One of the documents that we've been looking at is through Healthcare Excellence Canada now, but formerly the Canadian Foundation for Healthcare Improvement. And that document is a primer for cultural competency, and it's called The Journey We Walk Together. And there's a couple of tools, and one of the tools is a self-assessment guide, and it really gives that opportunity to think about your own practice if you're interested and you're thinking about how you provide care when you are called upon to provide care, and if you work particularly from Indigenous perspective in Canada. And these things just ask you to reflect on whether you do something, you occasionally do it, or you don't do it, and think about what are some ways that you could look for opportunities in your practice. Things, for example, like I want to learn more about Indigenous cultures. I familiarize myself with cultural elements of Indigenous communities that I serve. I understand the impact of Indigenous experiences on health. I seek out those who can help me understand Indigenous practice. I seek clarification if necessary when working with Indigenous clients and with co-workers. And I think you can apply all those pieces for any culture. Certainly that's an invitation. There's others for sure in terms of how you might engage in reflective practice. But we've been reflecting on this particular tool and this particular document, both at the individual level from a healthcare professional perspective, but also a tool for our organization. I wanted to talk a little bit as well and share with you a model that I like to think about, and this is the cultural competence model of health, a model of care, excuse me, and this is a model that was developed by Josepha Kempfina-Bacot, and as a nurse theorist, a nurse modeling in terms of working with transcultural care. And this model speaks about how you develop cultural competence. And the assumptions of the model are that cultural competence is a process, it's not an event. There's a direct relationship between the level of competence of healthcare providers and their ability to provide culturally responsive healthcare services, and that cultural competence is an essential component in rendering effective and culturally responsive services to culturally and ethically diverse clients. And it speaks to 5 different areas. So cultural awareness is that self-examination that we spoke about, and that exploration of your own cultural and professional background, and recognizing any biases or prejudice that you have. Cultural knowledge is the process of seeking and obtaining educational foundations about diverse cultures and ethnic groups and understanding the worldview of others. Cultural skill is the ability to collect relevant data regarding the client's presenting problems and thinking about what you're assessing in terms of that particular client. For example, a physical assessment. Are you considering the physical differences in body structure, skin color, or physical characteristics, laboratory variances when you are doing a nursing assessment? Cultural encounters is the process that encourages the provider to directly engage in cross-cultural interactions with clients from culturally diverse backgrounds. So refining to modify your own existing beliefs about a cultural group and really getting to know what that culture, what the characteristics, and knowing the people. And then the last piece is cultural desire. And this is so important. And it's the motivation of the provider to want rather than have to engage in the process of becoming more culturally aware and culturally knowledgeable, skillful, and familiar. And I really like this quote that people don't care about how much you know until they first know how much you care. And certainly the motivation of the provider and having that cultural desire and demonstrating a genuine passion to be open and flexible, to accept differences and build on similarities is so important. And anyone who would share their experience in working within different cultures, and we have certainly a lot of experiences from staff that would speak to the importance of becoming involved and understanding your biases, understanding what you know and what you don't know, and looking for opportunities to learn and build relationships within the culture that you may be living and providing care. So here's a few examples I just wanted to highlight for us in our region. So you'll notice on the top right-hand side that one of our Indigenous staff in one of our community clinics is sharing culture and preparing Penitsiak for some of the staff and sharing some cultural elements. On the right-hand lower corner, staff are participating in Nalyanuk Night, which is a cultural event in Inuit culture on the north coast of Labrador. To the left-hand lower corner, a staff member displays the Moravian star in their window at Christmas time, and this is a cultural piece for that particular area of northern Labrador, and joining that solidarity of recognizing the importance and doing similar to what other homes would have in the star in their window. In this, on the upper corner, shows a staff member partaking in activities that are very cultural in terms of ice fishing, char fishing, and with other members of the community. In this particular situation, the nurse was her first encounter, and the community member said, "Well, you have to eat the eyeball. That's a expected thing on your first time." Well, that nurse was brave enough to eat the eyeball, and many people that were also fishing that day were really impressed that the nurse did the cultural piece that was common in their culture. So just that whole bigger piece, and in the middle, of course, you can see the relationship building with a provider and family, and just getting to know people, engaging encounters that just to get to know people and understand. And you might not, lots of people who provide culturally appropriate care and safe care may not have the opportunity to live and work in community, but how do you think about how you get to know the culture, ask questions when you're doing your assessments, those sorts of things, and create that trust and that interest so that you create relationships with the people that you're providing care for. So what are some of the health system responses? Well, the first, the basics really for us at this point, I believe in Canadian history, certainly is the Truth and Reconciliation Calls to Action. The commission was officially launched on June the 1st, 2008, with the purpose of documenting the history and the lasting impacts of the Canadian Indian residential school system on Indigenous families. So there were 94 calls to action, but there are some particular to health that we're really leaning in and focusing on what is it that we can do to have reconciliation and to create relationship and build trust with Indigenous peoples that we serve. So certainly some of the ones that certainly impacted, first of all, calling upon government, all levels of government, to acknowledge that the current state of Aboriginal health in Canada is a direct result of previous Canadian government policies, including residential schools, and to recognize and implement the healthcare rights of Aboriginal people as identified in international law, constitutional law, and under treaties. And specifically, to establish measurable goals to identify and close the gaps in health outcomes. And some of those indicators really want to be looking at the gaps, including infant mortality, maternal health, suicide, mental health addictions, life expectancy, birth rates, infant and child health issues, chronic diseases, illness and injury incidents, and the availability of appropriate health services for Indigenous peoples. Another one is calling upon the federal government to recognize, respect, and address the distinct health needs of the Métis, Inuit, and off-reserve Aboriginal peoples. Creating or sustaining additional and having funding for Aboriginal healing centers to address the mental, physical, emotional, and spiritual harms caused by residential schools. Another important piece is recognizing the value of Aboriginal healing practices and using them in the treatment of Aboriginal patients in collaboration with Aboriginal healers and elders where requested by the patient. Some of the ones for sure from a systems perspective is calling upon all levels of government to increase the number of Aboriginal professionals working in the healthcare field, ensuring the retention of Aboriginal healthcare providers in Aboriginal communities, and providing cultural competency training for all healthcare professionals, and calling upon particularly medical and nursing schools in Canada to require that all students take a course leading with Aboriginal health issues, dealing with Aboriginal health issues, and annual reports and data, and recognizing being able to report on data that shows our progress towards meeting these calls to action. The other piece for us, certainly in our organization, we have focused on growing our own, and that certainly includes the value and the importance, the absolute importance of Indigenous peoples in our region working in their communities and feeling comfortable and being a part of the healthcare team, and purposefully recruiting and educating Indigenous peoples to feel to provide care. Also, for us, growing our own. So that's certainly a part of that. And we know that leads to greater retention of our healthcare providers in communities and growing relationships. We're really happy to see the recent announcement about the nursing program that will be starting in Happy Valley Goose Bay in September of this year, because we know that's going to give us a really good opportunity with our Indigenous partners to talk to students, to think about health nursing as a profession, being able to be educated locally and have their experiences, their clinical experiences locally, is going to be very, very important for Indigenous peoples to look at the opportunity to be educated very close to home, rather than have to leave and go outside of Labrador, as an example. And so certainly looking for that piece, certainly very, very important. And we have purposefully been working with our Indigenous leaders and looking for opportunities to speak about in terms of interactions and partnerships that we've been forming. The second piece is Health Excellence Canada. And again, I spoke to a little bit ago about the journey we walked together, which was a Canadian Foundation for Healthcare Improvement document and a primer that gave recommendations about how we could improve. And I want to say that cultural safety is not something that I can define or measure. Cultural safety needs to be measured by the individual, by the community, by the Indigenous group, or by the group of people. It's not something that we can measure in hours. It'll only be when people say that they feel safe, respected, that their culture is recognized and considered in the provision of care. And so while we are working towards these, we recognize that we partner with all of our Indigenous partners and communities and individuals. And so the Health Excellence Canada is a couple of pieces. Certainly, as I said, the document that we've been working with through the Canadian Foundation for Healthcare Improvement and the Canadian Patient Safety Institute, of course, have now come together to form Health Excellence Canada. And we have been looking at an assessment tool for our organization, looking at how we, as right from the organization, from our board to the education that we would deliver, how do we support staff in when they're reflecting on their practice, when they're looking for education, and a host of things of different measures that we've been trying to do. And the other piece, certainly a recent statement by Health Excellence Canada in March of 2021, excuse me. So just post the Joyce Echuan event that happened in September of 2020, Health Excellence Canada led a roundtable and developed recommendations of how we would take action to address racism in healthcare. And certainly the recommendations, what we have found, have certainly been things that we have been working on and certainly learning from this, particularly in organizations developing and investing in training for all members of the organization, to be trained in First Nation and Indigenous history and anti-Indigenous racism, developing a mechanism for accountability, including evaluated metrics, creating individual physical spaces for healthcare environments, within healthcare environments for Indigenous peoples, adequately resourcing initiatives outlined in the overarching Indigenous strategy, developing a mechanism for reporting racism and celebrating First Nations people, staff, history, and communities. And so many of these recommendations, I'll speak a little bit about some of the things that we've been doing in our organization over the past couple of years. Since 2019, we really began some of this work in earnest. So what we do know is that colonialism and racism have influenced which knowledge systems are valued and which are not. And it's resulted in the dominance of Western biomedical knowledge and devaluation of Indigenous knowledge systems and ways of knowing. And knowing this and coming from the experiences that we were having with our Indigenous partners and hearing both right at the patient level, looking at concerns that were being brought forward from individual patients, from communities, we knew that we needed to take some definitive, purposeful steps in working together with our Indigenous partners to work towards cultural safety in our organization. So in 2019, we embarked on a journey with our Indigenous partners, the Nazi government, Mushwa Innu First Nation, and Sheshe Innu First Nation, along with Indigenous Services Canada, through some funding that we had to do a project that started as a project in terms of cultural safety, and mobilizing together to create a culturally safe spaces in healthcare for our organization. And we hired a cultural safety liaison, and in that project, we started to look towards things that we could do that would be guided by Indigenous ways of knowing. And some of the pieces that we certainly started with were and this particular picture shows a tent, an Innu tent that we put up, and this is in Happy Valley Goose Bay, and that's the acute care and our long-term care in the background, and being able to demonstrate and actually engage our residents, for example, in long-term care, and staff to be able to engage together and learn about culture, and purposefully creating opportunities for education are some of the things that we've been trying to do. Certainly, we look towards the cultural, the model for cultural safety through the Canadian Foundation for Healthcare Improvement, and for organizations in terms of creating cultural awareness, sensitivity, working towards cultural competence and cultural humility. And some of the pieces in that particular model, so cultural awareness, of course, acknowledges our differences and doesn't seek broader context or understanding, or wanting people to acknowledge the differences between my culture, for example, and the culture of the people that I serve, and just recognizing that everyone is not like me. The second piece, certainly in cultural sensitivity, acknowledges different ways of seeing the world, and trying to integrate some changes in practice or behavior in individual practice, but also within the organization. Cultural competences system elements are aligned and respect other cultures, and being able to look at ways that we would educate and support people towards cultural competence. And cultural humility is a lifelong commitment to self-evaluation, and not only self as individuals, but as our organization, to really look at and redress power imbalances and recognize and maintain relationships that are based on mutual trust and respect between the Indigenous peoples and the organization, or between Indigenous patients and the care provider. So some of the various pieces that we've been doing, is develop a need in our project. We started by developing a needs assessment that we administered to our staff to see where people were, what their level, what their desire for education and their recognition, and what they wanted to see in terms of support for them. We developed an action plan, and we began to implement some education with our staff. We had some funding for some projects through the International Grenfell Association. One of the ones that we identified that we were hearing loud and clear was about how we cared for families during palliative end of life. And so we recognize, for example, that families come, particularly with the Innu culture, that families like to gather in larger groups. Now, this has been difficult during pandemic, but what we were able to do was we had a room that we were able to work with our Indigenous partners to redevelop, and we had funding to bring in Indigenous cultural elements into that room. So it's a larger family room for someone who's palliating for family to come, and it's closer to on our acute care unit, for example, in Happy Valley Goose Bay, it's closer to the exit, so people can come back and forth and be able from family to care and provide comfort and care for each other, close to the chapel and also to the outside. So that was a really good example of a project that we did together, and certainly it will be continuing to evaluate the outcome of COVID. Certainly, and visitor restrictions caused certainly a lot of difficulty, but certainly well received and working, and it was informed by both Inuit and Innu culture in terms of what sort of things would create comfort, pictures, for example, what toys might be in a place for children to play with, what things might be important that might be reminders and comforts from a cultural perspective. So that was an example of that particular work. We're also working on another project that we're completing, and again, COVID has impacted in some ways, and that is about culturally safe care and culturally safe places and reclaiming space. And so when you come into our hospital in Happy Valley Goose Bay, we receive funding to procure cultural elements of art and other forms of Indigenous cultures in our region, so that people, when they come in, would see indications of culture and giving that sense that this is our space together, and recognizing the cultures of the people that we serve. We were also able to purchase the Labrador tents, so Inuit and Inuit cultures, and be able to use them in ways, as I showed in the video, or excuse me, in the picture a little while ago, engaging residents, for example, of our long-term care to be able to go into the tent. And that's certainly very satisfying and very soothing, and very much cultural elements of what it means to be in the tent from that perspective. We also we provide services and care for Inuit population during their annual gatherings, and our physician group provides, and our paramedics provide supports in case something happens at the gathering. In this past year, we were able to purchase a tent and provide the care in the tent, because of course everybody at the gathering would be living in tents, and so that care was also provided now in a tent, versus bringing up a trailer and that sort of thing. Certainly feedback from our staff. We've created onboarding where all individuals now complete an onboarding piece with regards to Indigenous cultures in our region, and part of our learning as they're onboarded into our organization. And looking at ways, and we've done group sessions and partnering with our Indigenous partners to be a part of the training, to be a part of that education, and actually speak their truth in terms of culture, and creating more opportunities for relationships as well. From the top of our organization, in 2020, we did our strategic plan for 2023, and a part of that was examining our values. And it was important for us to ensure that our core values included culture. And so one of our core values now is culture, and being inclusive and respecting the diversity of our region, and care, ensuring that care is provided in ways that are fair and reflective of the knowledge, the values and beliefs and cultures of the people we serve. And that was an important piece of leadership from our board level, and to demonstrate and to live out those values. And we're still working on that for sure. As well, one of our 3 strategic directions for these 3 years is our first issue is about being people-centered, person-centered. And so just highlighting as our overall goal, creating a culture of person and family-centered care, but particularly in ways that are respectful of cultural values and reflect the diversity of our region. And by 2023, we have some indicators, of course, in terms of our person family-centered strategy, implementing mechanisms to gather input, but particularly about collaborating, planning and partnering with Indigenous stakeholders to build cultural competencies amongst our staff. And that will be evidenced by increased staff cultural awareness and surveying, and improving patient satisfaction in delivery of cultural safe care. We're working with our working group around an Indigenous identifier in our own region, so that we would be able to map out, for example, client relations activity, any concerns, through an Indigenous identifier, and being able to use that identifier in terms of planning with our partners. So some of our key activities, I said, our cultural competency assessment. We did an Indigenous cultural competency safety survey with all of our staff, and we're going to use those findings to be able to administer again and see where we are, and to measure that growth. And some of these are process things. As I said, it's very important. We will have culturally safe care when the people that we serve identify that they feel safe. We've done cultural competency education, Indigenous culture and awareness plan. We are in the process of transitioning from the working group that we had to an Indigenous Advisory Council, which will include all of the Indigenous groups in our region. And we're working on and finishing up the development and implementing an anti-racism policy for our region. And those things are still in progress. And we're working in, again, trying to work with our partners to do those pieces. So one of the pieces certainly, is around, and I showed this little picture at the beginning, but I wanted to highlight that we want to meet with people, and this is an example of meeting with our partners. This is at gathering in 2018, and the group, some of the people you might recognize, some of our nurses colleagues in the province, certainly our Indigenous elders and Indigenous Services Canada as well. And in this particular meeting in the Innu tent, we were talking about maternal child health and looking at, and the elder was speaking about her experience as in raising children and in their culture, concerns about maternal child health, and how we might work together collaboratively to improve outcomes for maternal child health. And one of the pieces that has come from that is the working towards Indigenous midwifery, and particularly supporting both First Nations in Labrador towards education in midwifery in their culture. Another piece that we had gotten approval through the IGA was to actually train, educate people to become doulas, to be supporters in as doulas do from that perspective, as attending in birth or going to prenatal, for example. And we were able to train 20 individuals, and primarily they were Innu individuals who wanted to be able to bring culture into labor and delivery and to support in culturally appropriate ways. And this particular piece I just want to speak about as well. Part of that was, and you may have seen this article, part of that work was a desire for an Indigenous woman, an Innu woman, who is leading the work around midwifery, to have a birth of her baby in a traditional Innu tent. And so we worked with the family, we worked with our insurer as an organization. It was a out-of-the-box piece of work. A physician and one of our nurses were willing to provide care. The delivery happened in the Innu tent on the grounds of the hospital in Happy Valley Goose Bay. But we felt that it was very important to look outside the box and how could we do that. It doesn't, I'm not saying that we do that every day in that sense, but we were able to work through into insurance and things about, obviously, to have an agreement with the mom and family about how care would be provided and those sorts of pieces. But we worked through it together so that mom was able to deliver in the Innu tent, her grandmom close by and her mother, and that was very important for her. And we were really glad to partner and look forward to other opportunities to partner that are so for culturally appropriate and in ways that make sense. And just a few more other pictures just to demonstrate some of the other pieces that we have been doing. So on the in the middle, we had our board. We've had education with our board, and in this particular one, an elder is speaking about the Innu timeline and talking about the Innu experience in Labrador and the impacts from a health perspective. In the far left, far left bottom corner, this is a walk that some individuals had done in Happy Valley Goose Bay on Orange Shirt Day this past year, and also other activities that we had done around Orange Shirt Day and creating awareness and standing in solidarity with Indigenous peoples. On the right in the bottom, there's some staff that were able to travel to a trading post just outside of Nain, Labrador, and learn about some of the history around the trading and the impacts on Indigenous cultures. On the far, on the right in the upper corner is a arts and cultural center in Nain. That is a good opportunity for staff to learn about Indigenous culture, about the Inuit culture in Labrador, particularly in the North Coast, in the Natsiavut. And so opportunities that we're doing. We don't have it all together, but these are some of the things that we've been doing. And in partnership with Nunat Civic Government, Mushawa Innu First Nation, and Sheshi Innu First Nation, and bringing in Nunatuva Community Council, and trying to come together where we can all come together and under an Indigenous Advisory Council to speak about what are we doing, what can we be doing. We need to be working with both the leadership, but also looking at working with patients and partners, and learning, because this is a journey that we are walking together, and we want to see change. We really do. I would also just want to took a few little notes. I would really encourage you, to read and look for opportunities, certainly online or books and that sort of thing. A few things that I thought about. My Indian is a book by Chief Measle Joe with Sheila O'Neill that has recently been published. That would be, I think, a really good from Mi'apekek First Nation on the island. I really enjoyed We All Expected to Die, which was a book. It sounds a little bit funny when I said it that way, but enjoyed reading the book, even though it was a difficult book. We All Expected to Die was a book regarding the experience of Indigenous peoples in Labrador with the pandemic of 2018, the Spanish influenza. And it was written by Anne Budgell. And I really felt, and I read it actually in 2018 when it was released, and I really felt that there was a really good opportunity to really get some insight into the impact that the pandemic at that time had on Indigenous peoples in Labrador. And I felt that it really gave me the opportunity to reflect as we work with our Indigenous partners over the past couple of years, and understanding the concern about the current pandemic and the impacts. There is another book. Andrea Proctor has recently released a book called A Long Journey, which is the experiences of residential school survivors in Newfoundland, Labrador. And that's a book that I think would be a really good opportunity to read as well locally. There's also a course that we've been encouraging, and we're hoping to be funded through the International Grenfell Association. It's not a really expensive course to get your certification. I think it's $61, but it's offered through Coursera, but it's called Indigenous Canada, and it's the University of Alberta, and it's a 13-module course that really gives you a good history of Indigenous history in Canada, and understanding the Indian Act, understanding the implications of institutional racism, the residential school system. So those are some of the recommended things that I would recommend that you may want to think about reading. I want to thank you very much for the opportunity to present today.